Hi, I'm Martin Prince, and I'm going to be talking about pulmonary embolism in COVID, a challenge for CTA, and opportunities for MRA. I have nothing to disclose. This map of New York City shows the distribution of COVID positive cases, where those regions in red having the highest number of cases, and recently antibody testing in those red regions showed nearly 50% of patients to have been exposed to COVID. The New York Presbyterian Hospital is located in Manhattan, associated with Weill Cornell, and has multiple other spots around the city, reflecting the spectrum of New York City patients. And we're going to tap into data from a number of those hospitals. This data, of course, because New York City was the epicenter of COVID, the first official case being March 1st, and by March 12th, hospitals were increasing capacity, canceling elective care, and by March 20th, an executive order from the governor closed all essential businesses, and NYP massively increased its ICU capacity. By April 1st, there were more cases in New York City than China, UK, and Iran combined. And Cornell medical students had their clerkships disrupted. Many were reallocated to the newly created intensive care units, and many were hired to create a COVID research database, which we tapped into to obtain information on pulmonary embolism imaging. So RRIB gave us access to data from 4 NYP hospitals. And before I show you the data, I just want to mention that at that time, the ACR had recommended against imaging COVID patients, partly fearing exposing radiology personnel to the COVID virus, and partly wanting to preserve protective equipment, which was badly needed in the wards and intensive care units. Because every time you use a CT scanner, someone would have to suit up and spray and let the room sit for an hour, highly inefficient. But in spite of the obstacles to imaging, overall 15% of COVID positive patients ended up getting a CTA to evaluate for pulmonary embolism because the symptoms and suspicion was so high. We had a total in these 4 hospitals of 8,000 COVID positive patients, but only 3,965 were actually admitted, and those are the patients for whom I'm going to share data. Of those, as I mentioned, 15% had a CTA to evaluate for pulmonary embolism, 100 were positive, 486 were negative. Now, this column labeled all COVID positive versus PE with p-values compares the patients with PE to the entire cohort of nearly 4,000. And this other column of p-values compares just those who had CTA, PE present versus PE absent. And immediately you could see that liver function tests were more abnormal in the patients with PE, reflecting involvement of the liver with COVID. And in fact, we did have several cases where intraluminal thrombus was seen in the intrahepatic IVC. I'm going to show a few more parameters, D-dimer being the most significantly associated with pulmonary embolism, both comparing to the full cohort and to the CT PE absent cases. Patients with PE were more tachycardic and also more tachypneic and had a lower oxygen saturation. At the imaging features of the CT, we see more ground glass opacities with PE and more consolidation or possibly infarction in patients with PE. Not much difference in pleural effusion, but interestingly, a very high rate of right heart strain, with 21% having bowing of the intraventricular septum towards the LV. Now, looking at our outcomes, death, interestingly, would be expected to be higher in those COVID patients complicated by pulmonary embolism. But in fact, we had a lower rate of mortality, suggesting that diagnosing PE and treating with high-dose anticoagulation may be life-saving. And perhaps patients who are not getting diagnosed, not getting a CTA, many of those may have PE that is going undiagnosed, causing a higher mortality. Acute renal failure was very common, seen in 25% of patients, but no difference between those with and without PE. So wrapping up, I want to point out that 25% with acute renal failure makes CT more challenging because it requires iodinated contrast and offers an opportunity to use the macrocyclic GBCA, which we now believe to be safer in renal failure. And of course, non-contrast MRA or using ferromoxetil are additional opportunities for MR. The high rate of right heart strain is another advantage of MR, which is better at assessing cardiac function, and MR is even better than echo for the right heart because the sternum blocks the echo view of the right heart. We noticed several of our patients required multiple scans because after an initial negative scan, there was ongoing suspicion of PE, and of course MRA can reduce radiation exposure. Wound cleaning is now similar for CT and MR, down to about 15 minutes. We assume all patients to be positive, and we have many efficiencies like having patients arrive in MR-compatible clothing. But I think the most important finding overall is that the diagnosis of PE appears to be life-saving. 14% in those positive versus 21% in the overall cohort, suggesting we need to be imaging patients for PE, and MRA is a great tool for this purpose. Thank you very much.